there we go. I guess there's only one at a time. No, that was great. Thank you very much. That's fantastic. So real quick, I'm going to give you a little bit of my perspective from San Diego too, and then we'll jump into some questions. Jose mentioned a little bit of my background in the past, but so what I do now also in San Diego is part of the Navy's population health initiative in the region. Just for those who are maybe unfamiliar with San Diego County has 3.2 million people. It's the 5th largest county in the country. It's bigger than 20 states in America. It's bigger than Alaska, Wyoming, and Vermont combined. Our little county. The military is interested in this county because we have almost 20% of the beneficiaries in the county. So in our interest, we love these partnerships. We love to have the movement towards health. One of the things that we touched upon, Larry and Nicole both touched upon, is almost a fantastic structure that Larry's put together here and what they've done with all the different partnerships around the country. There are other ones, as Larry alluded to too, right? Nicole kind of touched on that too. There's other ones that maybe don't have all of these characteristics, maybe not as structured, very loose, if you would, potentially. San Diego may be one of those areas with that. We've started about 5 years ago with a number of initiatives. The county began its initiative called Live Well San Diego, which maybe some of you have heard about, led by the County of Health and Human Services Agencies, which then garnered a number of different partners around the community: schools, public health agencies, veterans groups, private healthcare systems, all to say, let's figure out a way to move into this health sphere. We launched a childhood obesity initiative, which has made some dramatic results in the southern part of the county. There's been another initiative called the Be There campaign, which is a goal to reduce cardiovascular disease throughout the county, where we have a table where about 7 healthcare systems are all at the table, competing healthcare systems, by the way, sit at a table every month and talk about ways to make that happen. For the last 2 years, we even won a CMMI grant to make some of that happen, to measure hypertension, to promote better healthy living in the cardiovascular disease space. So it's taken a lot of these principles to that level. I think one of the things that we can learn from San Diego, and I think a lot of regions can learn from this study, is how to enhance themselves if they're kind of just on the cusp of not maybe having a charter, not having kind of solid funding, kind of just talking a little bit, maybe almost using this as a checklist to move there. I think San Diego would be one region to use these kind of principles to move into that future. And I would suspect many of your regions that you've been familiar with, that maybe not on the top 12, so to speak, but maybe part of the 70, et cetera, they have a lot of those characteristics. So it's been really, really interesting to see some. So maybe why don't we jump into some questions? I'll start myself with a couple of questions for the panelists, and then feel free, we'll maybe do a question or two, and I'll try to package them to make sure that we get all the key concepts out there. So why don't we start, we kind of touched a little bit on this, Larry and Nicole, about, maybe you can talk about some of the recommendations and the challenges that these folks face. I know I can probably touch about in San Diego. What are the challenges to make something like this happen? Funding, she says.
Okay, so let's just talk about funding, because I'm sure that's the one everyone's thinking about. Core, I think, to our success in the Quad Cities has been the anchor leadership of the 2 nonprofit health systems and their sustained leadership and support over time. They've provided that backbone of support, essentially creating my staff position, the office position, to support the work of the board that has allowed us to evolve and grow over time. Certainly, we've had additional support from other community organizations and from individuals. Our approach to fundraising is still maturing, but this past year we actually had, for the first time, 100% participation by all of our community board members and or their organizations in supporting our work, which is a wonderful benchmark from a fundraising perspective. And then we've also had success with grant writing at both a local, regional, and this past year now at national level, as we became part of the new Partnerships to Improve Community Health grantee award cohort. So we're really encouraged and enthused about the growth potential that 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 opportunity will bring to our community. But in terms of support and sustainability, I really do think it starts with having local leadership commit to this idea and commit to this sort of a partnership to know that there's stable support over time.
I'd like to add just a footnote to Nicole's earlier comments and these comments. In the Quad Cities, there are two health systems, as Nicole mentioned. You all need to understand that they compete on everything. They compete on everything. Both have services across the river. Both are good. Two very excellent CEOs, Doug Cropper and Rick Seidler. But they've agreed, and their predecessors agreed, with respect to the Quad City Health Initiative, they would cooperate and support it. So they compete on everything except on the Quad City Health Initiative. They both serve on the board, they both commit resources to it, and they are committed to its success. Why? Because both of those CEOs and their boards believe that a healthy Quad City initiative is good for the whole community. It's good for the whole region. So that's a nice story. You can be competitors and you can collaborate on something like this. Nicole put her finger on sustainable funding. Obviously, we have recommendations along those lines. I just make two comments. One, it's our opinion as a team that partnerships like Nicole leads are helped enormously if there can be one or more anchor institutions. It doesn't have to be a hospital or health system. It can be a major employer. It can be another party who really stand up and make a longer-term commitment of financial resources to provide a underpinning foundation for the initiative. So we really think we've seen evidence that where partnerships have one or more anchor institutions who are really committed and make a longer-term commitment, it provides a much stabler base. A second thought in that genre is that while these are arguably very successful, imperfect but very successful partnerships, relatively few had gone so far as to make the case as to the impact they're having on the health of the community in relation to the costs they are incurring. When you go to foundations, when you go to major employers, when you go to health plans to ask for support for partnerships like this, it helps immensely to have an impact statement that documents what that partnership is achieving, the impact it is having in relation to the costs, the investments that have been made in it. So we also were struck by, in these 12 partnerships, putting Kaiser aside, very few health plan engagement in helping to support the partnerships. Many of the partnerships have health plan folks on the volunteer roles, even on the board, but very few have made any financial investments in it. Similarly, virtually all have many volunteers, as Nicole was saying. It turns out to be thousands. And so employers have allowed their staff people to go and contribute as volunteers to the partnership, but very few major employers have made financial investments in the partnerships, even though it seems to us that both health plans and the employers are direct beneficiaries of successful partnerships. So we think as you try to broaden the base of funding, the idea of having documentation, evidence-based impact statements can be very important in making the case for employers and for health plans over time to choose to make an investment in the partnerships. All along the line of, if these things don't have sustainable funding, they're chasing grants all the time and can't make enduring long-term commitments.
Quick supplement to that. So everyone heard of the acronym WIFM? No. WIFM, what's in it for me? All right. So let's talk about, just to quickly add on to the funding question, the healthcare systems, they can put into this partnership. Why not just do the same funding for their own local population? Why put this into this kind of collective collaborative? It's a provocative question, but how would you guys overcome that?
Well, For us, I think it's about the recognition that in a community our size, our community is our community, right? You know, both of our nonprofit health systems interact with the same population base in our community. And Sunny and I were talking a little bit earlier too. I think one of the other things that we've seen over time is that there's been intangible or derivative value to the Quad City Health Initiative partnership in and through other community partnerships, and we in turn have benefited from other community collaborative points. For example, over the last several years, our community worked very hard to create a single Chamber of Commerce, and we now have a Quad Cities Chamber of Commerce. Huge development over time in terms of our thinking as a community. Well, obviously, if you're working with the senior leadership in a community of our size, many of the folks that serve on my board serve on many other boards together as well. And so there are opportunities to work together, whether it be through the vehicle that we're providing through QCHI or through other community boards, enhances just overall our community's capacity to tackle difficult challenges across sectors. And essentially, you're investing not only in creating health or in supporting the work of an organization, but you're also investing in creating this collaborative infrastructure and capacity in a community that can have all sorts of other wonderful benefits for communities' development over time. So I think it's that vision that it's not just about the issues that you're working on, but it's also about creating capacity for your community to grow and change over time that has been important for us and could be a powerful thing for others to leverage as well.
I'll just pick up on that in the world of vision. There's a partnership in New Hampshire, based in Keene, New Hampshire, for which the vision is to make Chester County, in which Keene is located, the healthiest community in America by 2020. And that was a dream of the local hospital CEO, Art Nichols. Chester Medical Center is affiliated with Dartmouth-Hitchcock. But Art Nichols was a CFO, became a CEO, and had a vision that even Chester Medical Center and its medical staff, doing a great job of caring for individual patients forever, was never going to really make a difference in the health of the community. It just wasn't going to make a difference in the health of the community. So he created a vision. Why don't we aim to make Chester County, the whole county, not just the patients that Chester Medical Center serves, the healthiest community in America? And Art Nichols was able to convince the community to rally around that idea. What a bold, bold vision to make Chester County the healthiest community in America. Now, how do you measure that, and how do you keep track of progress, and can they get there? Well, that's going to be a real challenge, isn't it? But the idea that Art had was that we cannot serve our community best by only taking care of the sick and injured patients who come to our hospitals. And other charismatic leaders or visionary leaders in other communities had a similar vision. In New Ulm, Minnesota, a very prosperous rural community in southwest of Minneapolis, with a very high rate of coronary heart disease, very high rate of heart disease. And a physician who was part of the Minneapolis Heart Institute, big cardiovascular cardiac care group in Minneapolis, had been caring for those people for 25 years. And he too said, we're not going to get there by just curing more heart ailments. We have to do something better. So there's been a partnership created in New Ulm, the vision of which is to reduce or eliminate myocardial infarctions in that county. That's a big, big vision, focused but big. Again, because a physician who'd been caring for all these heart attack victims for all these years said, this is not going to do it. This is just not going to do it. We've got to do something better. We've got to get at the social determinants, the economic determinants, and the other determinants of health and solve it. So there's a multi-year partnership at New Ulm focused on that part of improving community health. Just a footnote to that, these 12 partnerships, when you read the report, some of their missions are quite narrow and specific. Some are quite broad and bold and challenging, like the one in Keene, New Hampshire. But they're all based on a leadership team making a determination of all the health needs in our area of all the health needs and priorities, what should our partnership tackle? And our team came to feel that all of those were very legitimate, very broad or the very focused. Quad City Health Initiative is a broader vision. That's great. Some are more focused, and that's great too. So long as you have programs and services and metrics and know where you're going. And that gets back to the funding, then I'll stop. If a partnership cannot demonstrate to current or potential funders that they are making a difference on the elements of health that they're trying to affect, then they're going to lose support. So there's got to be an ability to have metrics that link to the measures that your partnership and all its parts are trying to influence if you're going to be sustainable.
That's great, Larry. Nicole, thank you. So just to see if I get this right, that when we go to start these partnerships, the WIFM, what's in it for me argument, one is to make sure that it aligns to the interests of the community, whether it's narrow or bold. Make sure we have some kind of structured leadership to push that. Nicole's point of there are secondary benefits as part of that sell to the WIFM is pretty important and can be articulated or even thought about. I would add maybe a third idea to make sure that when we get these other partners, healthcare systems, nonprofits, government agencies, all kind of engaged, is the idea that if they're really moving to this goal of health, they can't do it alone. They just can't do it alone. That's the key need for wanting to join in this. Otherwise, many healthcare systems can sometimes think, well, I've got my own wellness program, I've got my own transportation service, I've got my own this, or the county agency can say, I can deliver care with the community clinics, or et cetera, et cetera, et cetera. But it's far less effective than when we actually partner together. So that's one of the things we've seen in San Diego is to tap into the idea that there are other partners out there who can deliver services that are needed in a much more effective and efficient manner. The next question, to touch back up to what you mentioned, Larry, is this kind of measurable impact. We all know that unless you get that kind of like quick hit measure of what did we do here, it's going to wane. So can you guys talk a little bit about what happened how do we measure this when, especially, and you touched a little bit upon healthcare systems especially, like Lego my ego is Lego my data, right? It's my data system. You're not going to touch my data. Who's going to put their data all into making this kind of work? What did you guys find in this kind of putting the data into kind of measuring that impact?
There we go. Thank you. So I like to say we were doing community health needs assessments before it was fashionable. We started actually in 2002 with our first bi-state assessment. And that was a decision made by the founding sponsors of the Quad City Health Initiative that would essentially be our first project together to jointly conduct the community health assessment of our bi-state area. Now, our geography probably helped or contributed to that decision because since we have 2 local health departments and we do have data that comes from different sources through the states, it made sense to try to think about how we could get one picture of our community as a whole across the river. But that was actually the start of what has evolved to be a very rich partnership over the last decade. In 2007, we repeated our community health assessment process, and at that time we actually involved both our United Way and a local community foundation who were partners in helping to fund and also design the community health assessment. And then 5 years later, in 2012, we did our third one together. That was the first one sort of in response to the Affordable Care Act requirements, and so that actually moved more back towards the health sector, but involved as full partners our 2 local health departments and our federally qualified health center. And so we believe in our region, one of the first communities to have a partnership conducting a common community health needs assessment that included both of our nonprofit health systems, both local health departments and our FQHC. We're actually getting ready to embark on our 2015 study with that same partnership group. So to the question about data, again, foundation for us has been that joint planning that's allowed everyone to work from some common information about health status. And that planning process then, naturally leads into discussions about implementation and strategy selections once the assessment piece is complete. We have had the same sorts of challenges I'm sure many of you do in terms of seeing health status changes over time, right? There are some indicators like tobacco where we've probably been riding the national trend, and so we've seen them improve over time. We continue to struggle on other indicators that I know are of common interest across communities related to physical activity and nutrition levels. Mental health, behavioral health indicators as well has been another large area of focus for us. And so, we're still hoping to see those improve as we go, but the process of jointly measuring them and conducting that assessment has given us a foundation for our work together.
I would just offer a couple of general comments. That's a huge question. And in our recommendations, we speak to that. And just as a footnote, in the report itself, each of these recommendations is accompanied by about a page of text. It's our team's opinion that most of these partnerships, not all, have a great challenge in clearly discerning what are the overall health outcomes in their community, the overall ultimate health outcomes and measures that they want to try to effect, either moving that curve down or moving it up. And everyone in this room knows that bending some of those big curves, or almost all of them, is a long-term project. It's a long-term effort that requires sustained effort to bend those big curves the right direction. So we feel that these partnerships and their partners need to identify, okay, then what are the intermediate measures that we need to focus on that science will indicate clearly if we can affect those intermediate outcomes over time, we can bend the big curves. Some of these partnerships have done that brilliantly. Others have a ways to go. Even building a common understanding of population health, as we said a moment ago, and what are the appropriate measures is a great challenge for all of us. But partnerships that fail to have a clarity of what are they trying to influence in the end are handicapped, we think, in terms of sustainability and generation of funding. And for those who elect the big, tough measures to bend, they had better focus very clearly on some intermediate measures that they can affect and which science shows if they move those, they'll eventually move that big needle. And by the way, they have some value in and of themselves. So that's a very big topic, Sonny, and I think it's a great challenge for all of us in this room, not only the partnerships that we're talking about, but some have done a great job of it. We were chatting earlier in Detroit. There's a partnership called the Detroit Infant Mortality Reduction Task Force, sponsored by the 4 healthcare systems and many, many other parties in Detroit Metro, focused on reducing infant mortality in inner-city Detroit. The infant mortality rates in inner-city Detroit are strikingly bad. And that crisis generated, under the leadership of folks at Henry Ford, Kimberly Dawn Wisdom and Nancy Schlichting and others, bringing the systems together to tackle infant mortality in 3 inner-city neighborhoods. They are bending that curve, Sonny. And the report has an appendix that talks about that. It's really inspirational. Very focused. They want to expand that from 3 neighborhoods to more neighborhoods, but they are bending a tough curve. And they began by identifying the intermediate things they had to do in order to bend those curves. And they focused on those. It's an inspirational story that we think can be transported to other communities that have inner-city issues like Detroit does. So that's a good example of where they chose a very important measure, health measure, infant mortality. That was a crisis. And then what do we have to do to get there to bend that big curve? And they are bending it. It's an inspirational story.
That's great. Well, thank you. So why don't we open up, we're about halfway through our session now. Why don't we open up to some questions from the audience?
Sure. Dave Kindig, University of Wisconsin, and co-chair of the roundtable. Actually, I wasn't going to comment on metrics, but I'm going to give a plug. So our July, we've held off, the roundtable has held off dealing with population health metrics issues so far because of how complicated they are. But our July meeting is going to focus on that, and we don't know exactly how we're going to frame that yet, but we hope it'll add value to the conversation in the way that you're challenging us to. Thanks for the report and for the great presentation. So you say here that this was the collaborations that you look for were public health hospitals and others. And I'd like to ask you to comment about the others. So first, either from the 12 or from all 65 or whatever, or from literature. So I'm interested first, do we know anything about the epidemiology of who makes up these partnerships in terms of the others? Either just as members, or I'm particularly interested in your comment about anchor, the anchor function, and do we find that where there are anchors, they come from hospitals, public health, or from the business community, or from other sectors like education, or actually one of our roundtable members, Mary Lou, right here in front of me, she's from a United Way, that they kind of are the anchor institution in their community, I believe. So one, what do we know about it? And then, does it make it more complicated, as you add them, does it make it more complicated? It must, probably, but so that the partnerships may have more trouble, but on the other hand, in a multi-sectoral world, to get the kind of outcomes we need, is that sort of difficulty necessary?
Dr. King, just by the others, you mean anybody but the hospitals or public health agencies, correct?
Yeah, that's what I meant, yeah.
Maybe Nicole could comment on her partnership, and then I'll comment, Dr. Kindig, on the general case.
I'd be happy to. So we actually have ex officio positions for a number of organizations in our community that, as we redesigned our board about 4 years ago, there was agreement should always be present at the table. And so that includes some of the partners I've mentioned already, the hospital systems, obviously, public health departments, community health care. It also includes permanent positions for Chamber of Commerce, for a representative from the Rocca and Arsenal, for representatives of our local metropolitan transit and planning associations, and many other such organizations, including our local United Way and our local YMCAs. And then the balance of our board, our 25-member board, is structured to include rotating representatives from other sectors of our community to round out the community representation. So our education sector, community leaders in general, business, private sector. So we've given a lot of thought to our board and our governance structure and the composition of that board. In fact, that was the essay that I contributed to the report at Larry's request, speaking a little bit to how we shaped that group so that we would be sure to have those partners. And really, I think it's reflective of some of the comments made earlier today, the recognition of health in all policies and thinking about the need for, at a community level, all stakeholders to make their individual contributions towards community health improvement. We try to reflect those notions by thinking of that as we structured our governance.
Quick footnote, we asked each partnership leader to select one feature of their partnership that they and their team felt was special. Could be a structural feature, a strategy, a tough decision they made, or some other feature of their partnership, and each selected and wrote them up. And it's an appendix to the report. And Nicole spoke about the community board structure and how it's structured. Now, in the general case, we found that virtually all of these 12 partnerships have an amazing array of partners. And they range from anchor institutions who have made a major financial commitment. There's not as many of those as probably would be ideal. And then sort of a term we use, principal partners. principal partners are organizations who maybe aren't anchor institutions, maybe their commitments are not financial, but they support in other ways. And ordinarily, each of these partnerships have a policy-setting body that include many of the major partners around the table. And then there are partners with a small p that can be way over 100. And we certainly believe that the strength of these partnerships is increased if you add partners, either anchor institutions or principal partners or lowercase p partners, as long as they are committed and make a significant contribution. We'll publish an article later on that whole topic. We did not include that detail in the report. We did include in the report the composition of the policy-setting bodies, which is reflective of what we've just spoken about. They're pretty diverse. The short answer is virtually all of these partnerships have many, many organizations who are party to the work of the partnership at various scales and levels. And most run on the engine of volunteers, people who are volunteering from those organizations to put time into the partnership. So leaders like Nicole have to get awfully good at managing volunteers and engaging them in an effective way to contribute to the work of the partnership. And yes, Paul, it does get more complicated. When you get more people around the table, it automatically becomes more complicated. Along with that comes the concept of commitment and trust, as was stated earlier today. And we believe it's well to start out with a smaller group of organizations that are really committed and have trust and have experience in collaboration, and then gradually add on to that as the partnership gets its feet under it and has the ability to absorb and help to orient new partners. Plus, it's always a bit of a revolving door. Leaders come and go, some partners come and go, and so it's not like we're managing big corporate entities here. We're managing partnerships that are not incorporated entities, so that's another part of the challenge. Partnerships are flexible as a form of organization, but they are less durable and less solid than corporate entities. Some of these, by the way, some of these partnerships will almost certainly evolve into corporate entities over time.
Larry, real quickly, just a quick follow-up. What percentage of these anchor and principal partners are made up of the three different groups? Let's call them hospitals, public health agencies, and the others. What's the rough percentage you would say in each anchor group of the 12 example organizations you have here?
Well, all of these partnerships involve hospitals and/or parent health systems and public health agencies, period. That was a criterion
So it's 100%
to begin with, 100%. And some, as in Nicole's case, have more than one public health department. In Detroit, more than one public health department. And then after that, we'll have to save it for the article to give you the details on how many business organizations versus others.
Fair enough. Next question. Sir, when we go again.
So, yeah, thank you for the presentation. It's great work. We use the word collaborative, but there's many different types. And so I wanted to bring up two other dimensions and get your thinking on that. One is the Roundtable, for example, or the Primary Care Public Health Collaborative, which are national organizations with large, hundreds of thousands of members getting together to collaborate at that level on population health, on integration. So how do we look at impact in a setting like that, where you're not in a community doing the work? So that's question one. Question two, we heard Ted and Mary talk about macro, meso, micro, and we sort of think about the Million Hearts Collaborative, where we have a federal program funded by CDC through getting states together to work with local community programs. So you're having both a horizontal and vertical structure lining up to accomplish something. And again, how do you look at that impact at that level? And what have we learned, if anything, about that type of a collaborative yet? In the next minute, maybe. Thanks.
You should take this one.
Nicole would like me to answer that one. Well, I think, Paul, it's a very important question. We did begin our journey on this little study with a focus on the community level. And so as we conceived the idea of successful partnerships, our frame of reference was community level, sometimes large communities, but still at the community level. However, as we pull together the characteristics of successful partnerships, it did occur to us, and it has occurred to others, that probably with some adjustments, many of those characteristics of success apply to a much broader range of partnerships. And I think that warrants more thought. I think that whether it's a community-based partnership or a statewide partnership or a national partnership, unless there is a clarity of what the purpose is. Remember that these partnerships or alliances are independent parties coming together to achieve a purpose. Unless there's a clarity of the mission, the purpose, and what is the change that we're trying to bring about, it's really very difficult to ever measure success or to measure impact. So even at the community level, that's difficult, as we were saying earlier, but we can get our minds around it. So I think as we talk about the idea of statewide partnerships or national partnerships, it is equally important, though, for all of the partners in the alliance or partnership to come together on what is the purpose, the raison d'etre, the mission, and how are we going to measure our impact? What are we trying to impact? What are we trying to affect? Unless there's a clarity of that, there's always going to be ambiguity. Are we winning or not winning? So those would be my thoughts, Paul. It's a huge and important question. But I think there's merit to thinking how those characteristics might apply to those kind of partnerships.
Well, I'll add one thing, one thought, and that's that I'm very heartened to hear the discussions today about seeking alignment at a national level or sort of thinking federally, because when there is not alignment at that level, obviously the impact is magnified at the local level. We've had the good fortune of being in receipt of several grants through various organizations with very similar purposes, but they're just distinct enough that they've actually led at the local level to sometimes some confusion in terms of who's going to be leading the charge on what issue. And so, you know, while we welcome those opportunities to be able to receive support from organizations outside of our community, it's also helpful when we're able to leverage and work together in our community as our usual patterns would dictate, rather than needing to respond to specific requirements or processes or tools that are dictated from third parties.
Sure.
Bob Griss with the Institute of Social Medicine and Community Health. This session has highlighted voluntary partnerships as a way of conducting community health assessments and improving the efficiency of the coordination of medical care and public health. But I don't hear any attention to how the governments at the federal and state levels, the ones that have the major investment in healthcare delivery, 60% nationally of healthcare expenditures are public dollars. I don't hear how that money can be leveraged so that incentives are created at a community level to go through this planning process that you're describing, and that was actually institutionalized in the 70s as health systems agencies. Now, they weren't all successful. Some of them were better than others. Rochester, New York City are good examples. And I'm wondering if there are lessons from those experiences, particularly in leading to closer collaboration between social determinants of health and medical care, where savings in medical care can be redirected as a funding stream for many of the social determinants of health. Can we get to that stage, or is it really necessary to repeat this wheel that was invented many years ago?
I think that it's a really great question. In our report, there is a recommendation, number 11, that talks about policy level support. And we give some examples in the report, although we're not studying state level initiatives. We did talk about 2 states where there is policy level, state level support for encouraging collaboration between public health world and the hospital health world. They are New York and Maryland, but there are other states as well. So there is concrete evidence, though, that state-level policy encouraging collaboration between public health and hospitals will bring about more of it. We would encourage in that same recommendation those public sources of funding, Medicare, Medicaid, to think about what they might do to encourage the development of partnerships like we're talking about. We also encourage health systems to think about that. I want to comment on it just briefly. So we have public policy, state and federal, that we think could encourage the more rapid development and growth of partnerships like these at a local level. On the private side, 70% of America's hospitals are now part of health systems, and that's growing. And we had in our study some examples of health systems providing significant support for these partnerships. I think if America's health systems, America's private health systems, were to overtly encourage partnershiping at the local level, that would accelerate it. And just as the support of Genesis and Trinity is supporting Quad Cities. So policy can take a public policy form or can take the form of health systems providing and encouraging the development of their local hospitals participating and maybe leading local partnerships. You've opened the door to a very important discussion. And these community-based partnerships like we are talking about certainly are not the ultimate solution to our healthcare problems. We're way too expensive. Our quality is way too mixed. Our population health outcomes are not very good compared to other developed nations. But it is a way. These partnerships are a way to get a stronger focus on community health and to galvanize the communities, the citizens, businesses, the schools, and other parties to pay more attention collectively to what is the health of our community and what can we do to improve it. So there is no single answer to the larger questions. We think these can be part of a larger solution to that.
Well, can I maybe add one thing to Larry? I think that was a fantastic question, sir. And one of the things that I know that we've been working on in San Diego, and obviously from the military side, we all know that the CMMI, Center of Medicare and Medicaid Innovation, is trying to pilot this. One thing to maybe consider is this report, it's pretty unique, pretty groundbreaking in my opinion. I think this is the beginning to shape the formation of what those policies may look like. I think with the direction, the vision you outlined is probably somewhere where we need to go. But how we specifically get there, it's a question mark. What policies, how do we fund that? What kind of percentages do we go back and forth? What kind of national goals do we want in certain communities? Is that federally determined? Is that locally determined? I think this will probably give us some of that data to form that policy that we'll probably see in the next 5 to 7 years as that starts to come out. I think we're still there. We're on that journey right now. It's going to take us some time, in my opinion.
Just to add to that, there is a little section in the report that talks about sources and levels of funding. And as I think we said earlier, most of these partnerships are lightly funded. There are some exceptions to that. They're largely lightly funded. Other than grants, there is very little there is very little public or private insurer monies in it. Putting Kaiser aside, Kaiser's the anchor institution for that big initiative that they are doing in all their settings. 70% of the funding of these partnerships comes from the hospital partners, 70%. Another 10% comes from private foundations. So the hospitals and health systems that are partners to these partnerships have stepped to the plate in a pretty major way. But again, if we could, through policy, encourage the health plans, both private and public, to invest some dollars in successful partnerships, we think it would make a big difference. Hospitals and health systems, of course, are required to produce community benefit, and investing dollars, as Unity and Genesis are in Quad City Health Initiative, is a community benefit, certainly. But it seems to me that the hospital should not be expected to bear 80% of the cost of managing these partnerships, not when the businesses are benefiting, when the health plans will ultimately benefit. I think it should be a more balanced funding picture for them.
Hi, Mary Pittman from the Public Health Institute. First, I want to thank Larry for continuing his outstanding work. And just as you were saying, I mean, this is a journey. Excuse me. You've been tracking these kinds of partnerships, particularly from the hospital perspective, for a long time. And I hope you're going to continue to track, because we're seeing some major changes now. And Nicole, thank you for going back to some of the roots, to the Community Care Network and some of the healthy cities. I think with more engagement across sectors really emerging from what used to be maybe more hospital-driven, we're also starting to see new funding sources, the community redevelopment funds, the Federal Reserve. Can you comment on what you're starting to see? Nicole, maybe, you know, what you're seeing at the local level. Are you starting to see some of those opportunities emerge? And can you also talk about leadership? Because leadership is so key to keeping this going. And what are you doing to bring the next generation to the table?
Well, I'll start then. So I have seen much of the same literature you all have, and actually the Wilder research in this regard has been very influential in my thinking. Locally, we're still at baby stages in terms of thinking about what that means. We certainly do have local city representatives and local elected officials as part of our partnership now, and I think that paves the way for working with other local city folks who are doing things like housing and transit, and sort of connecting those other sectors in their work more closely to our health agenda. But the issues that we've chosen to work on so far have been more in the classic sort of public health realm. And so I'm interested to see where that work goes as well. In terms of leadership development in our community, Larry alluded before to the fact that transitions are a fact of life, and that certainly is true for us. One of the things that I have noted, though, over time is that given now our sustained partnership and the longevity of the partnership for the Quad City Health Initiative, it is easier for me to recruit folks at all levels and across sectors to participate in our work than it was when I joined 12 years ago. So there's something to sort of becoming institutionalized as an organization that helps over time with recruitment and bringing folks on board. We've established partnerships with local Chamber of Commerce leaders under 40 type groups looking for folks to sort of bring into the fold. We encourage participation at multiple levels among our community partner organizations. In addition to board representation, we obviously have a whole cascading level of coalitions and teams and work groups, and so many of our organizations use those as opportunities to engage their emerging leaders in our work, and then we hope over time that as their careers grow, their work with us grows as well. So we're attuned to those sorts of things, but yeah, certainly it's something that's a challenge challenge in terms of thinking about engaging those non-traditional partners and also making sure that the support and the leadership for this type of work continues.
Are you seeing any youth engage with you?
We have through our tobacco initiatives. We've actually had, through our local tobacco coalition for a number of years, high school age groups that have been involved in community advocacy. And so in that specific case, we've actually had youth groups working with us. Some of our partners also have youth teams involved with other things, but that's been the closest association for me personally.
Mary, you know, I'm a realist. And it's been really the first half of my career. I'm a realist, and I spent the first half of my career really in hospitals and health systems. And I want to be a bit of an idealist, though, for a minute, and recount just an impression. In our journeys to these 12 communities and in reading nominations from 157, but sitting down with hospital leaders and health system leaders from these communities, it was a different dialogue than you would have had 5, 10, 15 years ago. It's really a pleasure to sit down with hospital CEOs and board members and other hospital staff members and talk about population health and community health and how we can work together to improve community health. It's nice, you know, it's nice. And I think that's beginning to happen. It's beginning to happen. And I think being part of these partnerships helps to educate and further develop that interest. Maine Health, for example, in Portland, the board of Maine Health has adopted improving the health of the communities we serve as their mission. And they've committed a certain amount of their investment earnings every year to their population health program in their communities. And then you think about the folks who are involved as volunteers in these partnerships, and we sat with 250 of them, whatever, and to have people from Parks and Recreation and from the county government offices and from the school systems be talking about what they are doing in their partnership to address high priority community health needs. It's a harbinger, I think. It's a reflection of a change that's occurring. And I think the presence of these partnerships, helps to generate that kind of interest in social capital and interest. Now, back to being a realist, this is a long journey, as you were saying, and we're not going to change things overnight. But I believe, and our team believes, the existence of these partnerships in these communities is changing the dialogue. It's creating a more awareness of the importance of improving the health of the community and having value for it and engaging lots of people from these communities in various ways in these partnerships. You can measure the number, can't really measure the effect, but I think it is significant.
Thank you. We have about 9 minutes left. Would you mind, sir, if we did Joe's question and another question? We'll have them answer both.
Sorry?
We'll do 2 questions, so feel free to ask your question. Sure. We'll ask another one, and they'll answer both questions at the same time.
Okay. Ron Bialik with the Public Health Foundation. I just wanted to talk about elephants for a moment. That in experiences that we've had working with diverse sectors, public health, healthcare, others, that there are always elephants in the room, and that we find it's important to invite them in, recognize them, make them feel comfortable, and actually have the discussion framed in a way that the elephants can be non-disruptive and not stomp out the partnership. And I'm wondering, in your experiences, I was looking at the characteristics, and I didn't see that characteristic of sort of recognizing the elephants in the room and addressing them. And I'm wondering if that was something that you saw as an important element.
So elephants in the room. Before we answer, go one more question. Why don't you come up too as well, ma'am?
I'm Mary Lou Gakey with United Way of Santa Cruz County, California, member of the Roundtable. You talk about the importance of having measurable goals, and I'd like to know if you saw commonalities across these 12 communities and how they set the goals, and did they engage their community residents in goal setting?
Goal setting and the elephants.
So elephants, yes. I would say, with respect to elephants, listening has needed to become a core skill for me. And, people always talk about that in terms of communication skills, but over time, I've learned that it's really important to make sure that when you leave the room, people have said everything that they feel they need to say, and if they haven't, that you have an opportunity to follow up with them offline before the group convenes again. And so I've certainly, I think, in my tenure in this type of work, grown in my ability to work with a group and to listen to what's not being said as much as what is being said. We actually tend to operate on a consensus basis. We very rarely take votes on anything that is important. We vote to approve minutes, but when it comes down to making strategic decisions, we operate on a consensus basis, and that's proven, I think, to be very important to make sure that all of the partners feel over time that their opinions are heard and that their perspectives are respected. It sometimes means that we've walked away from opportunities because we haven't had the consensus that we need to pursue a specific idea, but in some sense, you don't want to sacrifice that sort of long-term partnership for a smaller term objective. With respect to goals, for us, the goals and objectives that we've set have been largely based on that community health assessment work. So we relied very heavily on BRFIS type indicators and indicators from our community health assessment process to frame our goals and objectives at a population health level. And then we worked with our team leads and our volunteers over time to develop process type measures that allow us to assess whether or not we're making desired progress towards those goals. A lot of that has to do with whether or not we feel there's engagement, what our attendance looks like at meetings, if we set a common objective, if we've been able to accomplish it in the timeline that we've set. Standard things that you would expect and anticipate to see, but it's helped us to develop some sort of a way to evaluate whether or not we're making forward progress, especially knowing that it'll take many years to get to those population health changes.
I would just add that without exception, all of these 12 partnerships, without exception, all 12 of these partnerships have based their goals on assessment of community needs. Now, only a few of these partnerships do the community needs assessment for the community. Some do, most do not. But all of their decisions in terms of what they're going to focus on are based on community needs assessment. And most of those predate the IRS requirements for hospitals to collaborate with parties in community needs assessment. But as we said before, what they have chosen, what the partnerships have chosen to focus on varies tremendously from very, very specific healthcare issues or crises that they want to focus on to the very broader missions of, like in Keene, New Hampshire or New Orleans, trying to make their community or their county very, very, very healthy. So what they've chosen to focus on varies, but all of them then are forced to the challenge of saying, okay, if that's our mission, then how are we going to know when we get there if we're making progress, and what are the health measures that we're trying to affect, and how do we get from here to there? And there, in that zone, there's a lot of variation on how they've done it. We think that there's a great opportunity to help partnerships like this and other parties who are trying to improve the health of their communities by giving assistance, technical assistance and guidelines and concrete examples of metrics and measures and approaches that really work. In our report, there are, in that Appendix C, some examples of what some of these partnerships are doing, even scoreboards. There are several of the actual scoreboards are there that show not only what they've chosen to focus on, what they're trying to measure, but what the data look like. And some of it's pretty awesome and inspiring, and some of it is they've got a long ways to go, but it's there. So I think there's a great opportunity, and Paul and I have spoken about it a bit, for ASTO and for foundations and for other parties, the work at Wisconsin, many places, to help partnerships like this progress more rapidly in how they determine what they're trying to affect and how to measure it and what metrics to use. I think we could really advance the cause by some work in that zone. There's work being done, but room for more.
Last question, Mayor. You've been very patient. Thank you.
Thank you. Martha Gold again. I'm reminded at a meeting, this has been wonderful to hear. It's very invigorating. I'm reminded that Trust for America's Health and RWJ co-sponsored a meeting in October, which was bringing hospitals and public health together. And CEO, I think, of Nemours stood up and gave us a really wonderful account of programs that were going on, and basically said, these are money-losing propositions for us. Stephen Brill tells you about hospitals across the nation that are, business engines. For those who haven't yet drunk the Kool-Aid of this, what kinds of messages have you begun to sort of think about messages to bring other kinds of health systems on board to thinking this way? Because a lot of this at the moment is really not necessarily enlightened self-interest until the reimbursement systems change. So I'm wondering what thoughts any of you might have about that.
Well, I'll mention one thing that we've worked on a lot is actually engaging our private sector. And it's not quite to your question, but I think it's aligned because we've really focused on trying to help partners outside of the healthcare sector understand their role in creating health and how that overall has a positive impact on our region's economic development and growth. And so thinking about expanding the message beyond traditional health partners has actually been something we've been spending a fair amount of time working on. And so perhaps in a similar vein, helping others to see that it's more than just public health issues, that in the classic sense, but it's about community development and community involvement could aid in bringing folks on board who have not yet started this process. I'll turn it to Larry to see anything.
Well, I'm going to put my idealist hat on again for a moment. And yesterday, I had 2 telephone calls from 2 health system CEOs, nonprofit systems, one based in Ohio, one based in Colorado. And both were wanting to tell our team that they're going to take our recommendations and use that as a basis for discussion with their local CEOs to encourage them to think, if they've not already done it, to think about trying to form some kind of alliance or partnership in their communities to try to focus more on community health. I thought that was a nice message. Another state has asked me to come in June and meet with all of the CEOs in the state to do the same thing because this particular state exec feels it's very important for local CEOs throughout that state to move more proactively into collaborations focused on improving community health beyond what they do as hospital institutions. So those are just some recent things that I think are indicative, I think and I hope indicative of a shifting of the earth plates. I think we're at a different point now. I think we're at a point where more people from the hospital and medical community understand that doing what we've always done is important but not sufficient, and that we really have to focus on the populations we're serving, the community or communities we're serving, and reach out to school systems and to public health and to other parties who share a common interest and take new approaches, try new and different things to get after creating a healthier community and creating a culture of health. I believe we are at that point. Are we there where it's all going to happen quickly? I don't think so. But are we at a different point, at a better point in that regard? I think the answer to that is yes. And so if I'm correct, and if there can be some policy level support for this kind of endeavor, and if there can be more interest by health plans in this kind of endeavor, and more engagement by big employers like John Deere in these efforts, then I think we can see an acceleration, perhaps, whereby we begin to reallocate our time and energy a bit more fully to public health and population health improvement than we have in the past, where, as we all know, the vast bulk of our healthcare expenditures have been on the acute care side, most of it for chronic care, and it just hasn't worked very well. So we need to change our investment portfolios, and I do believe we're seeing a changing of levels of awareness and interest in trying other approaches, such as we're talking about today. At least I hope that's true. We'll see in the next 5 years.
Well, thanks to Nicole and Larry for this fantastic session. Just to recap, we've talked today a little bit about getting stakeholders involved. We've talked about the initial funding part. We've talked about goals. We've talked about what these partnerships can really harness for specific communities. We've talked about maybe the future, about what we're going to have to do nationally to really make these kind of partnerships not only thrive, but also grow around the country. So it's interesting, as I wrap this we wrap the session up, Larry, a lot of that stuff is right here. So the strong encouragement, this is a great report and a lot of great work to both you and Nicole, Larry. Thank you so very much, and thank you all.
Thank you so much for moderating, Sunny, and thank you to you, Larry and Nicole, for sharing your experience and wisdom with us today. And now it's time for a break. 15 minutes, and then we'll be back here for our last session related to asthma.